Hello, everyone, and a warm welcome to this webinar by the Global Innovation Hub for Improving Value in Health. I hope you are all doing well and staying healthy. My name is Reem Bunyan, and I lead the Secretariat of the Global Innovation Hub. I would like to welcome you and thank you for joining us to today's webinar, where we launch this report entitled Beyond Capacity Management: How Health Systems Can Ensure Value for Money in Addressing the Elective Surgical Care Backlog Created by COVID-19. The Global Innovation Hub for Improving Value in Health was established during the G20 Saudi Arabian presidency in 2020, with a mission to accelerate global transformation for health systems to deliver better value through sharing knowledge and experience and collaboration. The concept of value in health pertains to a system where health outcomes of the population, communities, and individuals are explicitly prioritized in the way resources are allocated to health and care. Value-based care aims to improve the health outcomes of people while optimizing health system efficiency, responsiveness, and reducing health system waste for the resources invested. Designing health systems that are rewarded for better health outcomes rather than remunerating for illness will shape healthcare provision in the 21st century. I would like to hand this over to my colleague, Dr. John McGhee, who leads the Value Intelligence and Policy domain at the Center for Improving Value in Health in Saudi Arabia. He's the lead author for this paper and the inspiration for us to look specifically into the elective surgical backlog that accumulated and has become an issue for health systems during and as we emerge from the COVID-19 pandemic. He will walk us through the summary and key learnings. Over to you, John.
Thank you, Dr. Reem. Hello, I'm John McGhee, Director of Policy and Knowledge at the Centre for Improving Value in Health. A warm welcome from me to the launch of this paper produced by the Global Innovation Hub. As Dr. Reem mentioned, I'll introduce the framework and insights of the report. But additionally, I'm delighted to say we'll hear from Dr. Meena Cherian, who will present a perspective on global impacts and policy measures for value-based approaches to the backlog. And I'll introduce her in full when we get to her section of the presentation. So looking forward to hearing from her. And I hope we'll have a little time at the end of the session for questions from the audience. So please feel free to add your comments or questions to the chat as we go. The COVID-19 pandemic is the most significant public health challenge the world has faced in a generation. And policy work that seeks to address its impact should first always acknowledge the extent of its human, social and economic costs, equally felt keenly at a personal level as well as at a country level. The persistence of long waiting times to access health services is a recurrent issue in many health systems and is one that's been dramatically worsened by the COVID-19 pandemic. Elective surgery is one type of health service that has seen substantial levels of cancellation and postponement as a result of the COVID-19 crisis. My intention in introducing this paper is to briefly talk about three things. Firstly, the approach taken in the paper to classifying different country level levers for addressing the elective surgical backlog and the resulting conceptual framework. Secondly, the hypotheses put forward for each lever on its expected impact on health system value. And finally, how we in the Hub see the framework being taken forward, both as a menu of potential policy options and, critically, as an agenda for policy research and evaluation in the coming months and years. Value-based care aims to improve the health outcomes of people while optimizing health system efficiency, responsiveness, and reducing health system waste. Earlier in 2021, we conducted a rapid review of available evidence, reports, and grey literature on the various approaches countries were taking to addressing the backlog of surgical activity generated by the pandemic. These approaches were classified into a high-level conceptual framework of supply and demand side levers. In selecting this approach, we were informed by OECD research, which suggests that the most successful policies for reducing waiting times and improving access to health services mobilize both supply side and demand side interventions, together with the regular measurement of progress towards achieving agreed upon value targets. So let's start, as I take us through the framework, with the available supply side interventions. When a shortage in provider capacity is perceived in healthcare, it's understandable that thoughts might first turn to increasing supply. There are policy options related to supplementing resources and funding, as well as those involving organising delivery and redeploying resources around the system. In this paper, these options are categorised under 5 levers titled Optimise, Extend, Expand, Coordinate, and Reconfigure. I'll go through these each in turn. Optimise is increasing the operational efficiency of existing healthcare facilities, staff, and assets. Many health systems have extensive experience in pursuing such operational improvement initiatives, achieving reductions in length of stay, increasing surgical operating room utilisation, and ensuring appropriate skill mix in teams, to name but a few approaches. There will often be complex organisational challenges associated with implementing, expanding, and sustaining this kind of change. Engaging frontline staff in operational efficiency change programs is always challenging, particularly so with the exhausted and often frustrated workforce that we observe moving into the 3rd year of the pandemic. Extend is a lever that relates to expanding surgical capacity by drawing more output from existing workforce and assets already in place. This includes financially investing and compensating existing resources for additional time, so there's a capacity increase, but usually at the same, sometimes at a lower, level of efficiency. This approach could involve adding dedicated diagnostic and surgical shifts, increasing working hours and offering more paid overtime, restricting time off, expanding individual or team roles, and reducing activities that are considered non-essential in the immediate term. Although this lever would likely have an immediate positive impact on patient outcomes and reduce the backlog of elective cases, it's perhaps best considered as a stopgap measure. It could be difficult to sustain in terms of costs and availability of workforce due to the additional pressure it places on already exhausted staff. The 3rd supply side lever is expand, where additional capacity is generated through the addition of new health workforce and assets. Such investments could centre on more human resources, additional equipment, or new facilities. We've seen examples where the health workforce is expanded by encouraging non-active staff to rejoin, for instance, retirees or shifting staff from part-time to full-time working. Capacity could also be expanded through the engagement of alternative providers, such as the use of private and independent operators and international partners. Assuming such alternative capacity can be identified, strong assurance is critical to ensure quality, safety, and value. While this might be one of the more expedient routes to addressing the elective backlog, it would almost certainly necessitate material upfront funding to generate a meaningful impact. Lever 4 is coordinate. Here, overall system utilisation is increased by diverting activity to facilities with available capacity and redeploying staff across sites. Such integrated capacity and workforce management is only possible if there is evident underutilisation within the local or regional health system that can be accessed. This lever typically involves collaboration between health providers and sometimes payer organisations to divert resources from busier facilities with excess to places with excess capacity. Underpinning this is the need for data on utilisation rates and service portfolios to achieve a coordinated outcome. Redeployment of staff between organisations may be facilitated where staff are fully cross-credentialed. The risks and almost inevitable short-term inefficiencies of introducing new staff to unfamiliar working environments would need to be carefully managed. The final lever on the supply side is reconfigure, but potentially the most exciting lever. This involves reorganising and transforming services to create additional treatment capacity. This could include altering the way services are being delivered, adjusting facilities, utilizing technology, and critically restructuring clinical pathways, as well as potentially changing incentives and mechanisms of payment. Many systems have been reconfigured in the short term to reduce the disruption caused by the pandemic by minimizing or diverting non-essential surgical activity away from hospital settings or segregating COVID and non-COVID sites. The pandemic may create a window of opportunity to make long desired but difficult to implement changes to treatment pathways and modalities. There is some evidence and experience that the pandemic is acting as a catalyst for lower intensity treatments, such as day case and outpatients, virtual services, and non-surgical alternatives. These 5 levers relate to changes in the resourcing and configuration of healthcare provision. I'll go on now to 4 further categories of policy options which were identified on the demand side. These were titled in the paper Confirm, Reevaluate, Rescope, and Scan. In Confirm, we assess and check that patients still require treatment and still prefer treatment under COVID-19 secure conditions. Waiting lists are dynamic, and patients identified for surgical treatment prior to the pandemic may not still require treatment. Patient conditions may have changed in unanticipated ways, and their health and social needs may also have changed. Different patient preferences for treatment and their perception of risk entering hospital facilities should also be taken into account. The reevaluate lever requires transparent, consistent prioritization and triage criteria to be put in place to optimize use of currently available resources. Patients who are best placed to benefit from treatment should be prioritized, and these decisions should be made transparently with the engagement of patients and the public. Consideration should be given to establishing multidisciplinary prioritization committees and deploying a prioritization strategy that meets the needs of patients while making optimal use of existing facilities for elective cases. The next demand side lever identified was rescope. Here, surgical treatment thresholds, risks, and benefits of surgery are systematically reviewed. For each elective surgical service, it can be assessed whether there have been material changes to the risk and benefit profiles of the procedures involved as a result of the pandemic. There is certainly now an opportunity to reinvigorate discussions on the need to identify and eliminate low-value elective surgical care. And of course, some treatments are now of lower relative clinical value in the context of changed risk profiles resulting from the pandemic. Finally, we consider the lever entitled Scan. It's important to ensure that health systems are equitable when allocating resources and capacity to address patient needs. Health systems must consider the likely needs of currently undiagnosed patients, as well as those already in the system on waiting lists. The post-pandemic success of health systems will not be judged purely on their performance in reducing existing waiting lists. Although the effect of scanning for new cases and integrating these with the currently identified health needs of the population will be to increase rather than decrease the demand for elective services, it will have a vitally important impact on overall population health. So these are the 9 policy levers identified in the framework in the paper. I hope you'll agree that the framework demonstrates that there are multiple policy options available, and it's clear that the elective backlog provides multiple ways of approaching the task of restructuring services, reviewing appropriateness of care, and reducing low-value care. The framework hopefully provides a common taxonomy and language to help health system decision makers navigate these available options. Going beyond this, once we identified the framework, it became possible to hypothesize on probable impacts of implementing each lever on health system value. Namely, how would we expect costs, clinical and patient outcomes to change when these levers are deployed? Taking into account and considering healthcare as a complex system, the actual value generated in a specific health system by a specific lever will depend on starting conditions, flexibility and effectiveness of implementation, and may be met by any number of confounding factors. However, providing a hypothesis with the supporting logic for the impact of each lever on value was intended to at least provide a guide to inform policy selection and also inform research priorities. The likely impacts on system costs and outcomes of using each policy lever were reviewed by the team in the light of the available literature. And this enabled the 9 levers to be classified into 4 very high-level groups. The first is those of low cost and high impact. Those would be the ones that would ideally be prioritized. Secondly, there were those that were high cost or required high investment, but also had a high impact. Those with a lower cost, but with a low impact. And then finally, those with a relatively higher cost and a low impact, which would be the lowest priority. What emerged was that 2 demand-side levers, reevaluate and rescope, were considered as requiring relatively less additional funding and would lead to greater improvement in outcomes. Supply-side interventions, such as coordinate and reconfigure, were seen as having the potential to improve outcomes, but may require significant financial investment. We concluded that policymakers should think beyond the 2 go-to policy options on the supply side, namely extend and expand, as these were costly, but were conceived as having less direct potential for transforming and improving outcomes. The COVID-19 pandemic provides an opportunity for health systems to employ value-based principles to reset, replan and renew elective surgical services. Health systems should continue to monitor the impact of the levers they deploy over the coming months and share these results, ideally incorporating and thinking about the framework. This is going to be key in measuring policy effectiveness and providing evidence to validate or disprove the hypothesis put forward on different policies' impacts on health system value. In closing my section here, it's also worth mentioning in passing that the COVID-19 crisis has demonstrated serious shortcomings in the timely provision of health services well beyond elective surgery, including primary care, care for people with chronic conditions and mental health services. A new wave of care backlogs caused by delays in screenings and treatments during the COVID-19 pandemic is likely to have serious consequences on health and well-being in the years to come. In the Global Innovation Hub, we're clear that new strategies and investments are needed to improve the responsiveness of health service delivery and to make health systems more people-centered beyond addressing the significant and apparently ubiquitous elective surgery backlog. At this point, I'm very pleased to hand over to Dr. Meena Cherian to provide a further perspective on the elective surgical backlog. Dr. Meena is Director of Global Health New Challenges at the Geneva Foundation for Medical Education and Research and former World Health Organization lead for the Emergency and Essential Surgical Care Program. Dr. Meena.
Can you see my slides? Okay, good. Could you see my slides, Dr. Sara?
Yes, your slides are up.
Okay. So a very good morning, good afternoon, and good evening from wherever you are listening from. And thank you, first of all, to Dr. Reem for inviting me and giving me this privilege to speak on elective surgical backlog during the COVID pandemic for value-based approaches. Thank you, Dr. John, for also introducing me for that kind introduction, and you have given an entire summary so aptly and so clearly. So now my role is that you will see in my presentation, because of my previous life, first of all, I'm very biased on putting the emergency surgical care services on the map of global health agenda. And also because I worked in the World Health Organization, where I created the program, helped create the program, which led to the World Health Assembly resolution. for the first time on surgical care and anesthesia care. So also you will find that I almost plead for addressing why this there's so much of elective surgical backlog, because it shouldn't have been. And therefore, I've divided in the next 10 minutes my talk on two areas. First, addressing the global impact of this stopping elective surgical surgeries. And secondly, the policy measures for value-based approaches. So in order to address this backlog, surgical backlog that we are talking in this paper, and today we are sharing with all of you, we need to take a step back and understand what the situation of unmet surgical need was before the pandemic. So you already know these reports, the Lancet Global Surgery Report and the World Bank book, the Disease Control Priorities. One volume was dedicated to surgery. That 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. 143 million additional surgical procedures are needed to save lives and prevent disability. There's already was a shortage of surgical health workforce, and the health systems were already weak in many of the low and middle income countries. And just to give you a sense of the health workforce shortage, this was a paper during my tenure in WHO that we published, and it was for the first time showing a global distribution of surgeons, anesthesiologists, and obstetricians globally. And here you can see that the low middle income countries, although it represents 48% of the global population, they have only 20% of this workforce. And I'll not go into details because of lack of time. But therefore, when you look at all this, then now you can understand the global inequity is magnified in the access to safe, affordable surgery. And we are talking about not the emergencies because they were not stopped. We are talking about the elective surgery, which was the first thing that was stopped. And because of that, either they were cancelled and postponed, 28 million approximately, or 70% of the elective surgeries had very serious consequences, which were cancelled. The health systems, as you can see, was already affected before, and here the health systems showed huge gaps, even in many of the developed countries. So then coming to the impact on cross-cutting health issues. How it was difficult to address, because even though we had the World Health Assembly resolution approved in 2015 and for guiding policies, it is strange that it was a first historic resolution on strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. And you can see from here, as I highlighted, that we cannot ignore surgical services. It is in so many of the WHO health programs as part of that, and also at the country level at the national health programs. If you look at maternal, child health, I'll not go into details, non-communicable disease, cancer, diabetes, etc., and cardiovascular, and neglected tropical disease. This is specifically like the Buruli ulcer and also the filariasis and the aging population. And it is very obvious that it is essential services, surgical services are part of the humanitarian crisis. So with this pandemic in the early part, when these elective surgeries were stopped or postponed, it had great consequences because the disease is advanced. Now they were requiring more complex and more costly surgical and anesthesia procedures. the health outcomes worsened, and to some extent also it caused disabilities. And we're talking about several things like orthopedics and other cancer. So if you can take a step back, and I'm sure you are well aware that surgical care is very important. But then if you were to translate this of the policies at the country level, then the first thing is that there has to be an awareness in the global community on surgical care as a public health issue. So this was a paper a few months ago, which we published. And among the many questions, I'll just highlight two questions, which was an eye-opener for me as well, that which health issues are a priority to reach the Sustainable Development Goals. And you can see where surgery stands. Only 19% participants from more than 1,954 participants from 118 countries. It was an anonymous survey. Thought that it was a priority. The next question asked was, okay, if the awareness was so little, and I'm sure in the audience, many of you have done public health courses, you know, in masters and diplomas, etc. And definitely it is taken for granted that maternal child health and non-communicable disease is part of the teaching topics in the public health course. And when we asked this in the survey, you can see only 27% of the people thought it is important to be addressed as a public health course. So when we look at the policy measures for this value-based approaches, it needs to be people-centered care. If we are going to optimize the health system's functions, it requires many things, and we want a sustainable health systems. We're all working on that as we are trying to achieve the Sustainable Development Goals and attain universal health coverage. But if you notice that it's the patient community engagement that becomes absolutely crucial in all this, when we are talking about universal coverage, when we're talking about policies. And we have to provide this evidence-based decisions for inclusion of surgical care, and therefore in future the surgical service elective surgeries are not postponed or cancelled, and they included in the national policies and plans with aligning with other programs. The other thing that we have to focus is also the strategies for balancing supply and demand side to reduce long waiting times. And for that, as earlier mentioned, financial investments is absolutely crucial. We cannot just sit back and think that yes, we'll have better health outcomes without input of financial investment into research and quality assurance, which are the two neglected areas where financial investments are not made. I will not delve in too much in details on the supply side investment, but I would like to highlight. We have to think of the protection of surgical health workforce first. Why? Because they are the people who are going to deliver the surgery services. We saw huge gaps in infrastructure, equipment, medicines, and the basic supplies to prevent the COVID-19 from PPE, masks, etc. We needed to support the physical and mental exhaustion of these surgical health workforce and align with other programs like vaccination program, mental health program, etc. The second most important is, why are we working? Why are we doing surgery? It is for the patients, for their health being, for their health outcomes, good outcomes. And here we have to protect the patients. So there are many in this paper in the Global Innovation Hub paper for improving value in health, it clearly shows many countries' examples. And here it is such a simpler example was this green clinical pathways. That means you decide which are the COVID pathway, people who are affected with COVID and the ones who are tested for COVID and are free from COVID-19. Another important thing will be with the changing, we know that every day we look at the scientific updates and find different variants and different areas, the management, etc. So therefore, updating these guidelines and protecting the patients have to be very, very speedily done, almost weekly basis or day to day has to be looked at. We need to reconsider the appropriateness of the care. I know with being anesthesiologist in my previous life as a professor, and also I have been a surgeon, not accredited surgeon, but in a rural hospital for 5 years where I operated. And I know the traditional, we still are some places still in the traditional training, clinical training. And sometimes it is overuse of surgical intervention. Sometimes we don't look at it, whether it's really low value of the care. I mean, is it being beneficial? Because that's because of the way we were taught. And I'm not saying that it was wrong, but we have to reconsider that. Reconsider, like, for example, length of stay of the patient. And above all, the patient safety issues, errors, etc., because this could be very detrimental for the patient's concern and to have faith in the health facilities. And from capacity management, we need to optimize utilization of operating time. Turnover, that is the main efficiency way that it's measured by the management. But it requires improving the processes. That is not emphasized. It's always about utilize the operating room. And I know the pressure that the surgical staff have in many of the countries. And the other thing would be reorganization of the surgical shifts, maybe additional teams, longer working hours, but they have to be paid, including retired, part-time, international surgical staff. Again, it needs to be having a quality assurance in this, because if we don't do that, it may be a different training somewhere else in another country or in another organization, and then we chip in. Quickly we come ask them to volunteer. Yes, it is very good faith, but you can also you should be aware of errors, patient safety errors. So when we are looking at supply side investment, we need to be doing monitoring and evaluation of not only the progress, addressing the cost and health outcomes of the patients. Coming to the demand side investment, we need to look at the severity of the clinical condition and prognosis when we are restructuring the waiting time for surgical intervention. A good example to show is cancers. Yes, it was an elective surgery, but we know now from so many published articles what are the consequences of early stage cancers, which was absolutely elective, and then what happened to them as the disease advanced. Investment, it cannot be demand side just clearing the waiting list, but investments need to be made in infrastructure. And I'm talking about the WASH, that is water, sanitation and hygiene, the equipment, etc. This is a time to actually rethink the entire structure of the surgical services. Reassessment of the benefit. I mean, do we have versus the risk? Are we risking the patients coming in during the COVID pandemic? I mean, I'm talking about now things are more structured, but earlier, is it going to be beneficial? Is it surgical, or we have alternatives to the surgical interventions? And as I always say, patient communication, and we have seen this during the entire pandemic to this day, that patient communication is absolutely integral for value for money. Why? Because there is so much misinformation. We need to debunk that misinformation. We need to provide scientific evidence in layman's terms, explaining to the patients and allaying the concerns of the patient. And when we are doing the demand side investment, we need to assess the backlog, the elective surgery, not just reducing it, not just with the speed that we have reduced, but also equity in allocation of the patient's needs. What are the needs of the patients? Some places they were not diagnosed early, and therefore we just pushed them away, and we did not address that when we are going to do the evaluation. Innovations, how digital technologies were utilized, because this COVID pandemic has shown us how much digital technologies has been utilized, and we are sitting in one of them right now, addressing through this in this webinar virtually to all you people. So I would take in conclusion that we have a huge opportunity for strengthening health systems, individually, policymakers, managers, and decisions, but through evidence-based decisions. And why? For integration of surgical care in the national health plans, also implementing the strategies for elective surgery during COVID-19, this pandemic, and for future readiness, which is so important. Thank you very much for your attention.
Thank you, Dr. Meena. Many points I would love to pick up with you from your presentation. I think overall really helpful in terms of bringing to life the level of complexity around this as a policy topic, the causes and potential responses, that what might at a political level seem like a really simple question. People are waiting for operations, and you can put money in order to get them to address that. It just reflects that it's much more complicated than that. The particular point around the restructuring of waiting lists and the treatment of cancer as, you know, at best sometimes semi-elective. You want to get in there before it's an emergency, I think is a point incredibly well taken. We do have a few minutes now just to pick up on a couple of points, if that was okay with you, Dr. Meena. I'd love to talk a little bit about workforce. Again, incredibly helpful slide around global distribution of workforce. I think it's easy, but probably right, to take almost a catastrophic view of where we are on global inequity of workforce, the increasing demand, retirement, exhaustion, and disillusionment of the staff that we have at the moment. I'm interested in your thoughts on what solutions do you see are promising, other than us indulging in a global competition for the same existing stock of qualified staff?
Thank you for that great question, because I think if our paper is all about also addressing very clearly, emphasizing the financial investments. So when we are talking about the health workforce, we have seen in the beginning, and it is not something I'm sure everybody has read, on the gaps that even the high income countries had for, you know, even the basic supplies. I mean, high income countries thought, yes, everything was available, and we were looking at the low income countries, how they will kind of address this on the surgical services. And many of this health workforce also were moved, since they stopped the electives. So they were moved to other pathways. For example, triaging COVID patients, you know, out of their comfort zone. But we never thought of, at that earlier stage, how to actually utilize the surgical health workforce in the same area, but in a more constructive manner, and also appreciating their long working hours. We just increased the working hours. They were all exhausted physically and mentally. There was no structure to give them support on that. There was no structure to help them financially. So there's some incentive. They were doing it because everybody was volunteer at that point. But at that time, we could have, looking back, I mean, it's very easy to say yes, but this will also allow us for future readiness, you know. Looking back, we could have used them much more, basic structure, you know, putting them in, like anesthesiologists took over the ICU, you know, in the critical care. I know it. And the surgeons could have then been used for other areas. Of course, everybody has, as a medical doctor, basic skills, but it could have been in many other ways to improve the elective surgeries. And here I would really like to emphasize one more thing. I'm sorry I'm speaking because I become very passionate about this elective surgeries, because it was very surprising, and I have had people with consequences, know of people with consequences. For example, nobody questioned nobody closed or elective surgeries or postponed them in maternal health, if you notice, because it is something understood in the national health plans, policies, in the big picture of the sustainable development goals, in the big picture of the attaining universal health coverage. But people dissociated that surgical care, the surgical delivery, is actually part of any of those programs, you know, and therefore I will stop here, that we have to start thinking in those terms in the big picture, how surgical services also completely is integral.
I agree greatly. I think there's a tremendous risk in perceiving elective surgical services as discretionary or optional, or you know, as an add-on. I think what you say about hindsight, I think is important as well. That I think it's possible to hold both views. That one, you know, everybody worked incredibly hard in tremendously difficult conditions to mobilize a response in the pace, and everyone should be commended for that. But equally, many of the decisions were taken as if it was a surprise that we had a global pandemic, but it was a tremendously predictable surprise that perhaps, again, we will learn the lessons of this pandemic and hopefully head off and adjust for the inevitable next one. As I said, lots of topics to pick up on, but perhaps I get another one close to my heart around patient engagement. We know here in the Centre for Improving Value and the Hub that patients often take less decisions around less intensive care, watchful waiting, and more value-based approaches when they are more engaged in their care. I wonder if you had any thoughts about, in your experience, what works best in elective surgical care around patient engagement, and anything in particular that can be done within the context of we're still trying to manage our way through the pandemic.
John, if you saw that slide where I shown the awareness, you know, in the global, the perception of surgical care services as a priority for sustainable development goals, or as a priority even in the public health courses, but the patients, you know, during this pandemic, the amount of the experts that, not the experts, scientific experts, but everybody became an expert in COVID-19 for management, for treatment, how it comes and how you can prevent, etc. But so who were the people? Many of the patients, you know, absorbed that news. And it did not, we can be very, very more constructive. Health facilities can be very much more constructive. Demand side, some places went down. Apart from the electives being shelved, the demand side also from the patients came down because of the fear factor, the concern, and it is absolutely reasonable to be concerned and to be scared. And there was nothing that we were able to address with the patient community, for the community, that the health facility could be make sure that how they can be protected, the patients can be protected. And that's something I think we did not come forth and emphasize and meet and communicate much with the patients, because maybe that would have also made a change. I'm not saying that they would have demanded more, but they could have been understanding why the waiting list, why they had to wait longer, or how they can still come, the waiting list is being restructured, etc. And that is an opportunity that we can learn we have learned the lessons, and it would be different from now on.
I mean, much like the many issues in rolling out good practice, there's no doubt that some organizations will have done very well around that, but also many organizations will have seen that as a second priority and maybe struggled a little with it. But certainly something where one would expect there to be significant value to be generated. One last question, and then we'll close. Well, I think hopefully people will agree. It's been a super interesting session around viewing COVID-19 as a healthcare challenge, but also as a financial challenge. So I very much agree that new money will need to be found, but also in the context of what the World Bank referred to as global economic scarring, that finding that money will never be any more difficult than perhaps it is now. Trying to put together the notion that new money will need to be found to address the surgical backlog, together with long-standing views that there's waste and inefficiency in healthcare delivery, and depending on who you ask, it might be 10%, 20%, 30% of money we spend doesn't improve patient outcomes. What prospects do you see for service improvements and organisation improvement and health system wide reimagining and change and transformation in a context where so many staff are struggling with exhaustion and may find it difficult to marshal the resources to make that change? Is it realistic to ask health systems to provide some savings in order to reinvest in new money for a new way of delivering health services post-pandemic?
That is, I think, one of the most important questions which the audience also must be, and the ones who are managers and also at the health facilities must be dealing with during this pandemic. And one cannot ask for additional finances when we have not evaluated, not done any evaluation, we have not created any. It's so important in every health facility or as a country as to what were the consequences of these delayed, postponed cases of surgical electives. So that's the key. So I know that, like, for example, one in our paper, US, you have an example of the US, and where it showed 50 billion US dollars were lost per month in 1 month or something like that for elective postponing, if I'm right. I may be slightly, is it 1 month maybe? And so they would have worked on it, but how many countries have actually looked at their own, in the national level, the consequences of this electives being postponed? And that could be one area where, if you put it forward, that is how investments, there's an appetite for putting investments, financial investments. Without that, we can keep saying, yes, the clinical figures, yes, the consequences and this and that. Sometimes, when you're sitting at the policy making policy decisions, you need to have the figures, how much it cost. And I think in the paper, it's very clearly emphasized. That is one, the cost. And how do we get the cost? Again, there needs to be some research, some more research on this, coming from low and middle income countries. what it costed.
Mm.
And that would give the financial policy makers also an idea at the country level or regional level as to why in future there needs to be reconsidering this elective surgery cases. I mean, that it doesn't have to be all electives need to be put forward. As we said, low value or the prognosis and what needs to be done initially. But we could have a plan, the in the National Health Plan, just like they have what are the interventions in maternal child health, immunization, etc. In the same way, the elective surgical cases could also be put forward. Without costing, without having an evidence why we are asking for the money, it is difficult for anyone to invest.
I think that's such a powerful and novel insight that in value-based healthcare, we always push for measurement and quantification. And sometimes it's viewed, I think, in the spirit of, we'll find out what things cost and how much patient outcome we have, because we want to take out, 1%, 2% of cost and drive some efficiencies. I think reframing it as we need these measures, we need to quantify the impacts as a strong foundation for a specific and quantified financial ask back to the system, I think is a really interesting and different way of seeing it. Thinking about the challenges of engaging clinicians in making measurements, it's a nice direction to take. Sorry, Dr. Meena, did you want to say something else?
Yes, just wanted to add to that financial. If you're asking for investment, it is sometimes many people do that. Okay, surgery is very important. Elective surgery was postponed or cancelled, but it's more important to push this with and align it, integrate it with the current existing national health programs. As I mentioned, maternal health, non-communicable disease. So if we move with that, aligning with that and not asking only for surgery, elective surgery, that could be something, a success. Thank you very much.
Oh, thank you. I will thank you for your comments and really fascinating and interesting discussion. Perhaps I feel I have to really, and it's appropriate for me to close the session by and any session around COVID-19. I'd like to just bring us back for a moment to the ongoing human cost of the global COVID crisis. And it's for me, it's always important, I feel, to acknowledge during what can sometimes be a relatively abstract conversation around national healthcare policy decisions, that the burden of death and illness relating to the pandemic continues to grow worldwide. And many of us, among which I count myself, have personal stories of losing loved ones to COVID. But the scale of this public health challenge shouldn't overwhelm us, and we should view the pandemic as really an unprecedented opportunity to reimagine health systems and see the pandemic not just as a huge healthcare, social, scientific and logistical challenge, but beyond that, a real turning point for the way we deliver healthcare services. Experimenting with and evaluating different approaches to reshaping surgical services as we move through the pandemic will be critical to our global national efforts to improve health system value for better health, better care, and at a more sustainable cost. It's left for me just to say thank you once more, Dr. Reem, for opening the session, Dr. Meena for very valued contribution. I'd like to thank you for joining the launch of this paper. The full paper is now available for download at the Global Innovation Hub's website, and I hope you'll get the chance to read and reflect upon it. And I'm sure this is just the start of an ongoing conversation around this incredibly important topic. Thank you again, and goodbye for now.
Thank you.